Bismillah ar-Rahman ar-Rahim. Today we are going to talk about benign ovarian neoplasm. I'm Dr. Manal Hamdy, Professor of Obstetrics and Gynecology, Cairo University. This is classification for the ovarian neoplasm, either functional, like the follicular cyst, corpus luteum cyst, cecal lutein, the inflammatory, like the tubo-ovarian abscess, neoplastic, benign, borderline or malignant, others like the endometrioma, those having enlarged polycystic ovary, or the para-ovarian cyst. Our topic today is the benign ovarian neoplasm. The classification of benign ovarian neoplasm, we have different classification with the ovary, a common site for various types of neoplasm. We have, first of all, the pathologic classification. They classify the ovarian neoplasm pathologically into benign and malignant tumors, with the benign generally much more common than the malignant, the first classification. The second is the clinical classification, whether cystic or solid tumor, with the cystic tumor more common and they are mostly benign, the solid tumor less common and are mostly malignant. The third classification, and this is the internationally accepted classification, based on the cell of origin of the tumor, whether it's coming from the surface epithelial of the tumor, we call it epithelial ovarian tumor, or from the ovarian germ cell, we call it germ cell tumor, or from the ovarian stroma, we call it six-cord stromal tumor. So it's either from the surface epithelium of the ovary, from the germ cell, or from the stroma. This is the serosal, or we call it the epithelial tumor. This is 60 to 70% of the cases, ovarian neoplasm, or the germ cell. This is 15 to 20% of ovarian neoplasm. This is the gonadal stromal tumor, 5 to 10%. We have other metastatic, but this is not our issue. We are talking about the benign one. Then the epithelial ovarian tumor, this, as I told you, originates from the surface epithelium, and this embryologically develops into Mullerian and Wolffian epithelium, differentiate into different types of epithelium. Whether these epithelial tumors are by far the commonest tumor of the ovary, this is 60 to 70%. They are classified into either serous cystadenoma, this is lined by cell mimic the tubal epithelium, or mucinous cystadenoma lined by cell like cervical epithelium. Then we have endometrioid tumor lined by cell resembling the endometrial lining. And lastly, the Brenner tumor. They have epithelial component similar to the transitional epithelium of the urinary. The second one is the germ cell tumor, and this originates from totipotent germ cell, and they may show either differentiation or no differentiation. They can do differentiation into embryonic tissue, will give various forms of teratoma. They contain element of the three germ layer. This is the ectoderm, the mesoderm, and the endoderm. This is the most common germ cell tumor, or it undergo differentiation into extra embryonic tissue like the trophoblast, giving rise to choriocarcinoma, or yolk sac tissue. This is endodermal or yolk sac tumor, or no differentiation, it gives rise to dysgerminoma, or what's called the ovarian seminoma. So the germ cell originate from totipotent germ cell, may show differentiation either into embryonic tissue or extra embryonic tissue like the trophoblast, the development of choriocarcinoma, the yolk sac tissue, development of what's called yolk sac tumor or endometrial sinus tumor, or no differentiation of germ cell. This will result in the development of dysgerminoma or ovarian seminoma. The third one is the six-chord stromal tumor. This is the least commonly encountered tumor. This is originating from two gonadal elements, either the primitive six-chord. This developmentally gives origin to granulosa cells in the ovary or serratoli cell in the testicle. It may give rise to malignant tumor like the granulosa cell tumor, androblastoma, also known as serratoli Leydig cell tumor, or the stroma of the gonad differentiate into Zika cell in the ovary or Leydig cells in the testicles, give rise to benign tumor, fibroma, and sarcoma. What about the pathology of benign ovarian neoplasm? As I told you, the epithelial ovarian tumor, these are the commonest ovarian neoplasm. Almost 60 to 70% of all ovarian tumors, they are essentially benign, could be borderline or malignant. We have serous cystadenoma, commonest benign ovarian neoplasm, 10 to 15% of all tumors of the ovary. They are bilateral in 30% of cases. The size ranges from 10 to 15 centimeters when first detected. They can present in one of three types. Either the simple serous cyst, this is the commonest type. They are unilocular with thin wall and filled with thin clear serous fluid. They have the lowest malignant potential in all epithelial tumors. Then the multilocular serous cyst, they may be multilocular with only few locule. This is serous cyst adenoma. This is the multilocular with thin wall. This is bilateral. This is bilateral in 30% of cases. This is the third one, the papillary serous cyst adenoma with papillae inside the cavity and on the external surface. Papillary serous cyst characterized by papillary growth, either inside the cavity or outside the external surface, usually multilocular. They have the highest malignant potential in all benign cysts, up to 50% risk of malignant transformation. And microscopically, they are lined by cuboidal cells, ciliated or non-ciliated. This is like the tubal-like epithelium. This is the bilateral papillary serous cyst adenoma. The samoma bodies, this represent calcification within the core of some of the papillae, occasionally occurring in benign serous cystadenoma, more frequent in the serous cystadenocarcinoma. They have no clinical significance. In pelvic X-ray, they can appear as calcified radio-opaque shadow. The second one is the mucinous cystadenoma. This is the second most common benign ovarian neoplasm. Usually, they are unilateral, having bluish or yellow transparent color. They are essentially benign, have very low malignant potential, less than 5%. This is the cut section of the mucinous cystadenoma, characterized by being multilocular with plenty of locules. They contain thick gelatinous-like mucin material, and they can reach even sometimes filling the entire abdominal cavity at this one. So the cut section, as I told you, it's multilocular, plenty of locules. They contain gelatinous-like thick material. They can reach huge size, and microscopically, the cyst wall is lined by tall columnar epithelium. This is similar to the endocervical epithelium and rich in goblet. What's the pseudomyxoma peritonei? This is a rare condition. We found huge amount of gelatinous mucin material in the peritoneal cavity, occur in association with rupture of a pre-existing mucinous cyst, may occur rarely secondary to peritoneal epithelial metaplasia or rupture of mucocele of the appendix or cancer colon. The diagnosis we can make it after the laparotomy, and it has a poor prognosis even after surgery because there is reaccumulation of this gelatinous material again after removal, with the 5-year survival rate around 50%. They are treated after surgical removal of the tumor by installation of radioactive intraperitoneal colloid chemotherapy into the peritoneal cavity, and of course after removal of this tumor and evacuation of the content. The Brenner tumor, this is a rare tumor, only 1 to 2% of all the ovarian neoplasm. They arise from Wolffian metaplasia of the surface ovarian epithelium. They are bilateral in 10 to 15% of cases, and the age group in women more than 40 years. The majority are benign, but may be borderline or malignant, and they are solid in consistency. This is benign but solid in consistency, usually small to moderate size, and we can find it accidentally during pathological examination of removed specimen. Microscopically, they have a characteristic appearance, epithelial cell nest with what's called a coffee bean nuclei, and some of them may secrete estrogen. We call it hormonally functioning tumor, and may even present by vaginal bleeding. We call it functioning. This is epithelial cell nest with the characteristic coffee bean. Then the second type after the epithelial ovarian tumor is the germ cell tumors. This is constitute 20 to 30% of all ovarian neoplasm. Mostly occur in young age women less than 30 years, and they are generally benign. Remember, this is the origin from a totipotent germ cell, undergo differentiation into embryonic or extra-embryonic tissue or no differentiation. We have the benign cystic teratoma. This is the only germ cell tumor which is common. This is 50% of ovarian neoplasm occurring in female younger than 20 years of age. This is the commonest ovarian neoplasm encountered during childbearing period and especially during pregnancy. They are bilateral in up to 12% of cases. This is the cut section or the open mature cystic teratoma, dermoid cyst of the ovary. They are of moderate size when first discovered. Most cysts have long pedicles, so they are liable to complication like torsion. I told you it's bilateral in 12%. With the cut section grayish in color, mostly unilocular, may contain only few locules with one large one containing small knob or mammilla, and they contain variable tissue including sometimes hair, teeth, bone mixed in species material. As they are derived from totipotent germ cells, they can differentiate in all 3 embryonic germ layers like the ectoderm, mesoderm. Ectoderm, for example, like the skin, hair, or sweat and sebaceous gland. The mesoderm, like the bone and cartilage. Endoderm, like the thyroid tissue, the intestinal tissue, or the bronchus. Microscopically lined by stratified squamous epithelium with sebaceous gland, they have very low malignant potential, less than 1%. They can develop into squamous cell carcinoma. Then the stroma ovarii, or they call it stroma ovarii. We call it a monodermal teratoma. This is composed of single tissue, and here it is hormonally active thyroid tissue. Occur in 1 to 4% of cystic teratomas. 5% only can produce sufficient amount of thyroid hormone to produce symptoms, and 5 to 10% develop into carcinoma. This is the microscopic appearance of the hormonally active thyroid tissue. The gonadoblastoma, this is again a benign solid tumor. The composition is germ cell with other cells resembling, for example, the granulosa cell and the Sertoli cell, and it is initially benign. Half of them they can progress to development of this germinoma or other malignant germ cell tumor. And almost all patients with this gonadoblastoma, they have abnormal gonad Y chromosome in 90% of. The third one is the benign six-cord stromal tumors. This less than 4% of all ovarian neoplasm, and they are almost always benign. Like the fibroma, this is rare tumors. They come from the stromal cells, and the age group is around the age of 50, and they are benign solid tumors. They are unilateral in most of the cases, more than 90%. Usually they have long pedicle and mobile, and they have lobulated white surface. Then sometimes with large fibroma, ascites may occur, giving the picture of what's called mixed syndrome. This is ovarian fibroma with ascites and right side pleural effusion. Usually this appears after removal of the tumor. This is fibroma with complications, cystic degeneration, and hemorrhage. This is the cut. Then the sarcoma or the Sika cell tumor. This is again rare tumor, occur in the post-menopausal women. Again, it's a benign, solid, and unilateral, and they are functioning tumor. They can produce estrogen, even to cause endometrial hyperplasia or postmenopausal bleeding, and rarely endometrial cancer. And microscopically, the tumor is formed of cells mimic the Sika. This is the Sika cell of the tumor with the estrogenic effect. It's hyperplastic endometrium and estrogenic vaginal smear. Then what about the complications of benign ovarian neoplasm? We have different complications like the torsion, hemorrhage, rupture of an ovarian tumor, infection, incarceration, and lastly malignant transformation. This is different picture for torsion with infarction, for hemorrhage, for incarceration or impaction, for rupture of ovarian tumor. The torsion, this is the commonest complication, and this may be either gradual or sudden, incomplete or complete, and maybe it's the initiation is sudden movement of the patient. It will initiate the torsion. If there is gradual torsion, there will be enlargement of the tumor with thrombosis and congestion. If it is sudden and complete torsion, it will cause, of course, occlusion of the arterial blood supply, leading to necrosis and gangrene of the. What are the factors predisposing to torsion? Number one, if there is moderate size of the tumor with long pedicle, that's why the commonest to undergo torsion is the benign cystic teratoma, because it does have a long pedicle and it has a fat content, so it can undergo torsion. Again, the simple serous cyst can undergo torsion. Logic, the large tumor cannot undergo torsion. Then the free mobility, there is no surrounding adhesions. This will facilitate the torsion. During pregnancy, due to displacement of the tumor, or during perporium due to lax abdominal wall, so this will produce torsion. The clinical picture, this patient will come with picture of acute abdomen, and you will find the tumor tender on palpation and tense. Of course, the treatment is either you can remove the entire ovary, usually via the laparotomy. This is the treatment of choice, especially if there is gangrenous cyst and there is no viable healthy ovarian tissue. On the other hand, if there is still adequate healthy ovarian tissue, you can do untwisting of the pedicle, you remove the cyst and you preserve the ovary. This is, we call it ovarian cystectomy. This is the ovarian artery and the uterine artery. This is how to do ovarian ovariotomy. Here you clamp and double ligate the ovarian ligament and the infundibulopelvic. And the second complication is hemorrhage. This may occur as a result of torsion of a pedicle or trauma to the abdomen, be spontaneous or even during pregnancy. Clinical picture, again, acute abdomen. The tumor is tender and tense on palpation. Actually, the treatment is ovariotomy, usually via. Then rupture of the ovarian cyst may occur as a result of hemorrhage or torsion, may be traumatic during labor or due to rough manipulation. Here it is following torsion of a pedicle during bimanual examination, during labor if the cyst is impacted in the pelvis, or spontaneous rupture. This is not uncommon. This is the rupture with clinical picture, severe pain, picture of acute abdomen, then internal hemorrhage with picture of hypovolemic shock, and if you palpate the abdomen you will find dullness in the flanks with shifting dullness. Then rupture of a dermoid cyst lead to chemical peritonitis, irritation of the peritoneum by the sebum content, while rupture of mucinous cyst adenoma may lead to pseudomyxoma peritonei. Treatment, I have to alleviate pain with sedative. I should do resuscitation for the patient to restore the blood pressure by IV fluids or blood transfusion. Then emergency procedure, ovariotomy via laparotomy, and I do peritoneal lavage to remove the cyst. Infection, this is the fourth complication, may be infected, for example, following torsion due to adhesions, or in the percorium following abortion or labor, or from a nearby infected organ like the appendix, appendicitis, or the PID, the pia albans. Clinical picture, it will be the picture of infection, fever, headache, malaise, and tachycardia, tachypnea. Plus, if I'm doing bimanual examination, the tumor fixed, tender, and rapidly increasing in size. Treatment, of course, ovariotomy via laparotomy and removal of the whole ovary under antibiotic coverage to control the infection. Should be broad spectrum antibiotic and covering again the anal. The incarceration, the ovarian cyst or tumor may be impacted in Douglas pouch, particularly if it has a large size, and it may cause pressure symptoms on the bladder or rectum, and during pregnancy it may cause like obstructed labor. Treatment is by removal of the tumor, surgical removal of the tumor by ovariotomy or cystectomy once. The malignant transformation, this is the last complications of ovarian tumor. Potential for malignancy is high, of course, in the solid rather than the cystic tumor, with the papillary serous cyst adenoma having the highest potential. This is up to 50%, followed by the mucinous, 5%, followed by the benign cystic teratoma. This is less than 1%. This is the least, carrying the least malignant potential. The clinical picture of benign ovarian neoplasm, symptoms, it may be asymptomatic. Many of them are asymptomatic. They can be discovered only during the routine clinical gynecologic examination or during ultrasonography. Or the patient may feel abdominal swelling, especially if the tumor is large. Some they may come with lower abdominal pain or heaviness over the site of the tumor, acute pain if it is complicated by either rupture, hemorrhage, or torsion or infection, or chronic dull aching pain. This is a large size swelling as in mucinous cyst adenoma. I told you it may fill the entire abdominal. Then the pressure symptoms, if the tumor is huge or it's incarcerated, like abdominal pressure symptoms, patient may come with dyspnea, palpitation, epigastric pain, or it may come with lower pelvic pressure symptoms like frequency of micturition or even retention of urine. Some with the functioning ovarian tumor like the Zika cell tumor and the functioning Brenner, they can present with menstrual disorder. The signs, physical examination, The small tumors, you can detect it only during the bimanual pelvic examination. It's felt to one side of the uterus. It's like cystic mass, usually cystic may be solid. You find it round, smooth, mobile, and it's separate from the uterus, meaning the movement of the mass is not transmitted to the cervix. This if large tumor, you can detect it, of course, by the abdominal examination. You found symmetrical abdominal enlargement by inspection, and during palpation, you can find the abdominal mass central, or it's deviated to one side of the midline. It has well-defined upper border and lateral border. Sometimes the surface is smooth or sometimes lobulated, and it's dense, commonly mobile from up downwards. If you do percussion, you will find central dumbness and on the mass and resonant flame. This is the upper pole can usually be distinguished. The lower pole can be palpated per vagina. The special investigations, ovarian swelling can be suspected clinically. You need to be confirming the diagnosis by ultrasound. This is of course the gold standard. Number one, it will diagnose the ovarian origin of the swelling, and it can differentiate between whether it's benign or malignant tumor. The small one can be detected by the transvaginal sonography, the large one, of course, by the transabdominal, and both of them can differentiate between is it uni or bilateral, cystic or solid, unilocular or multilocular, and if there is suspicious. This is a serous cyst adenoma with septation. Then the tumor marker, of course, to exclude malignancy, with CA125. This is significantly elevated in epithelial ovarian cancer, but it can be elevated also in benign condition like the endometriosis or the endometriomas. The carcinoembryonic antigen and the CA199, this is peculiarly elevated in mucinous carcinoma. The laparoscopy, this is if the ultrasound is not conclusive in the evaluation of adnexal swelling, you can go for a laparoscopy because it can differentiate between ovarian cyst or tube ovarian cyst. It can differentiate the solid ovarian fibroma from pedunculated subserous myoma. And you will go for IVP. This is if there is large tumor because this will delineate the course of the ureter. Then what about the treatment of benign ovarian neoplasm? Our aim of treatment is surgical removal of the tumor with or without the affected ovary. This is for fear of complication we talked about a few minutes back, like the torsion, rupture, or the malignant transformation. Then, what about the type of the operation? It depends on my patient age, whether she needs future pregnancies or not, the size and the type of the tumor, and is it complicated or not. Ovarian cystectomy. This is like shelling out of the cyst, then I will preserve the ovary. Of course, this if my patient is young or with bilateral cyst of small size like in the dermoid cyst, ovarian cystectomy, I can do it by laparotomy or by the laparoscopic ovarian cystectomy. This is best reserved for young women with small cyst. Then, of course, the cyst fluid, I should send it for cytologic examination. But many doctors or surgeons, they said dermoid cyst, you better remove it by laparotomy, not by laparoscopy. Why? Because laparoscopic surgery, they can carry the risk of dissemination of the irritant content. This patient may be complicated by chemical peritonitis. Again, the large cyst, better to be removed by treated by oophorectomy, because sometimes there is difficulty in inoculation of the cyst without rupture and later on dissemination of the content. Then if I remove a large cyst, there will not be adequate healthy residual ovarian tissue left. For fear of malignancy, This is additional factor, especially if it is large, bilateral, and this is ovarian cystectomy. Of course, I will do inoculation or shelling out of the cyst. Then I do suturing of the ovary with through mattress suture. Then I will preserve the oophorectomy. This is removal of the whole tumor together with the ovary. I will do clamping and double ligation of the infundibulopelvic ligament and the ovarian ligament, and the mesovarium can be. This is open oophorectomy. Here is the round ligament I divided and the retroperitoneal space. Then after I identify the ureter, window is created into the broad ligament and the ovarian vessel are doubly clamped by it. Then the infundibulopelvic ligament containing the ovarian vessel is then doubly. I can do it laparoscopic oophorectomy, like 2 to 3 loops are placed around the ovary and pinch it down across the ovarian vessel and the uterovarian ligament. Then the ovary is then excised, of course, distal to the last loop. The oophorectomy can be performed, as I told you, via laparotomy in all kinds of ovarian tumor. The laparoscopic safely established only in smaller neoplasms. The large one I told you, removal by the laparoscope, it's still controversial because of dissemination, the issue of dissemination of the cyst content, especially if there is risk of malignancy and possibly malignant cells. Any acidic fluid I should aspirate and send it for. Then panhysterectomy. If my patient is perimenopausal and she completed her family, I can go for total abdominal hysterectomy and bilateral salpingooophorectomy. They consider it as a preventive step against the future development of ovarian cancer. Thank you for your time and attention. I'm Dr. Manal Hamdy.